So I was supposed to have a debate with Bart today, but he didn't call. I think he may be held up. I've canceled on him before, so we'll get it scheduled. I'm actually very interested to do this debate because I don't know if you guys saw Bart's video about me. It was very negative, and him and I have had some very good conversations online, and we kind of agreed that there's a lot of grandstanding that happens in these social media things. I'm very interested in a lot of points he makes because I just haven't seen any science to back it, and but just because I haven't seen it doesn't mean it doesn't exist. So I'm fairly interested to have this conversation with Bart because it's so different than what I've been studying and what I've been seeing, and I'm very open-minded to looking at different things. I mean, there are definitely some positive ketosis studies. I definitely see where ketosis can help. I have put patients on ketosis diets before. I have been utilizing the vegetarian ketosis diet from time to time with different patients, though I don't feel like it's the ketosis that seems to help them. More like there's not much they can eat, so they stick on this one type of food. It's called food habituation, and because of that, they eat less. But when I'm looking now at the pathophysiology, I'm really trying to get into the mechanisms of disease because epidemiology is fairly clear. I could show you epidemiology that a high fiber diet decreases mortality. I could show you that a vegetarian diet has a decreased risk of mortality, but these are epidemiology. I know people online hate epidemiology. It definitely has its negatives. I criticize it all the time. Epidemiology gives me kind of a window into what could be a problem, but then I have to look for mechanisms of action, and that's what I've been looking at a lot lately. And when you look, for instance, at heart disease, I mean, we say, okay, cholesterol causes heart disease. It might not be that cholesterol causes heart disease. It's certainly part of heart disease because when I go in and do a surgery on someone's vessel, like I used to do some vascular surgery, I'm pulling out cholesterol out of their vessels. There's cholesterol that is getting subendothelial. That's where the problem is happening. But how does that cholesterol get subendothelial? That's what we've got to study. If you look at autopsy studies on children, they already have what's called atheromas. It starts at a young age of little cholesterol plaques, of subendothelial cholesterol plaques, and those tend to build. And what's causing that building? Well, what's causing the cholesterol to get into the first place? It turns out that may be flow mediated. So for instance, changes in flow and dynamics can damage the endothelium, or it can be that all of a sudden the endothelium have certain receptors on it that cause white blood cells to connect to these shear areas and then work their way into the subendothelial layer where they could set up inflammation. And what causes that to happen? It may be that it's a problem with nitric oxide, that these endothelial cells are not producing nitric oxide properly. And there's an enzyme that creates nitric oxide, and we know that that enzyme has a cofactor. And that cofactor, called tetrahydropaterin, if it is under significant oxidative stress, it will interfere with the production of nitric oxide and actually can form free radicals. So what would cause that to happen? What is the source of having this oxidative stress? Well, there's many different things that cause oxidative stress. We know, for instance, that if I give you sugar water, I mean, just breathing oxygen causes oxidative stress. I think Bart pointed that out in one of his videos. But what's interesting is if I give you sugar water, that will create oxidative stress. If I give you orange juice, you don't get that oxidative stress. And why not? Well, because there's flavonols and vitamin C and things in the orange juice that protect against that oxidative stress. And so one of the things I worry about with people doing a all meat diet is where are you getting your antioxidants? Bart said in one of his videos that you can't absorb antioxidants. That's not what I have seen in my studies, and so I'd be interested in that because we've shown definitely that you could absorb antioxidants, and that with blueberries you get 40% of the antioxidants into you, and so it's dose dependent. You eat more blueberries, you get more antioxidants. But those antioxidants are important because you need to get rid of that stress. The other thing is that fats can get oxidized, especially when you're eating meat, especially red meat, because it's got heme iron in it, and heme iron tends to oxidize fats. The other thing that happens is this endotoxin absorption. So when you look at endotoxin absorption, there's a suggestion that it could be saturated fat causing gap junction in these cells to allow endotoxin to get into the system. We know that in meat eaters, there's certainly more what's called LPS, lipopolysaccharide endotoxins in their bowel, and that somehow gets into their system. The other thought is that on a high meat diet, and I keep going back and forth to the microbiome, but if you are eating a more animal protein based diet and you're not getting a lot of fiber, you will start to create more bile producing, or we call it bilophilic, bile loving bacteria in your small bowel. And these bacteria are not producing short chain fatty acids. So you actually have a drop in your short chain fatty acid and a drop in your butyrate. And we know people on an animal based diet, if you look at them, they do have a drop in their butyrate producing microbiome. And if you have a drop in butyrate, butyrate actually feeds the enterocytes, the actual cells that line the intestine. And if you're not feeding them, they can't produce mucin, and that does have an effect on the exposure that your intestinal wall gets, and it can have an effect on gap junction. But what's interesting, when you look at flow-mediated dilation, so what that is if I give someone food and I measure how well their blood vessel dilates after it's been constricted, it changes with food, and that's crazy. Like a single meal could change the way your blood flow is affected, and it could therefore change some of these shear forces inside our vessels. So for instance, they did a great study by Keogh, K-E-O-G-H, in 2005 and in 2007. He's done multiple studies looking at flow-mediated dilation and different foods, and he saw that people on a low-carb diet had worsening of their flow-mediated dilation. But what was most interesting is he did a study where he gave people muffins, and that muffin could either have saturated fat in it, or it could have monounsaturated fat or polyunsaturated fat. And the muffins with the saturated fat were the only ones that actually caused a change in flow-mediated dilation. And what's interesting is I typically think, okay, if it's an endotoxin thing, then the endotoxin is probably coming from the food that you're eating, not from our bowels, because most of that endotoxin is down in the colon, and we're seeing an effect sooner than you would for food to get all the way to the colon. But we're seeing an effect with this muffin within a few hours, and that muffin isn't meat, so it doesn't have the endotoxin in it. So what is the effect? So it has to be something to do with the saturated fat causing an actual change in the absorption of endotoxin in our body, or it's because saturated fat comes in and it gets oxidized. Either way, it's hard to say. But what we do know is that once you have oxidized fat and you've got shear forces, so you're changing your flow-mediated dilation, which means this is acting on an endothelial level, and you're getting that fat to then be absorbed by macrophages. And what's causing that? Well, that goes back to this TMAO. So when we eat carnitine or choline, if you are a meat eater, then you have bacteria in your bowels that will break down your choline or your carnitine into trimethylamine, which then goes to your liver and becomes TMAO. And what we know about TMAO is it's got several functions. It may compete with arginine so that you're not producing nitrous oxide, so you're not getting endothelial relaxing factor, and so you're getting problems with your blood vessels clamping. It also prevents reverse cholesterol from your macrophages, so it blocks the ability of the macrophages to get rid of cholesterol, and that may be a big part of it. And also stimulates macrophages to secrete different chemicals that draw more macrophages into the area, and that also causes macrophages to take up cholesterol. So basically what's happening now is you've got people, we're having changes in the flow through our vessels causing shear forces on those vessels start to put up receptors that cause white blood cells to join in that area to then get into the cell. And once they're into the cell, they start causing inflammation, which draws more cells into that area. And these cells start to take in cholesterol, so that atheroma becomes a big plaque that could get a little cap on it. That cap breaks. Now you really have exposure to the blood cells, and you actually cause clotting factors, and you get a clot, and then you have a serious problem. So it's a very, very complex issue that's impossible to discuss with one paper. It's a much, much bigger process, but it's going on, and we know that through randomized controlled trials, and we know that it's having an effect, and we know that from epidemiology.